Okay, we are live.
Okay. Good afternoon, everybody. We are all set to begin our next in the series of webinars directed at postgraduate students and DNB students. And today the topic is going to be multiligamentous injury of the knee. This is an area which was really quite ignored till quite recently, but there have been many developments in this front where many of these very complex injuries can be tackled with proper techniques. And to tell us about this, today we have Dr. Arvind Gupta from our Paras Institute, Patna, who's going to talk to us about multiligamentous injuries of the knee. Arvind. So can you share your screen, Arvind?
Yes, sir. My screen is there?
Yes, we can see it.
Okay. Good evening, everybody. Thank you, sir. Thank you for the opportunity again. So I'll be discuss about the approach and the management of multiligament knee injury, particularly those associated with the knee dislocation or subluxation. So we all know about the knee ligaments, the central ACL and PCL. And on the medial side, we have this medial collateral ligament, which is having two components, superficial and deep medial collateral, and another is the posterior oblique ligament on the posterior medial corner. The deeper anatomy of the ligament around the knee should be aware of when dealing with this multiligament knee injury. Like we can see the superficial MCL start over the femur, just proximal to the medial epicondyle, and it travel around 6 centimeter below the joint line in the posterior half of the proximal tibia. And the posterior oblique ligament attached over the proximal part of the tibia, just near the semi-membranous tendon. Similarly, on the lateral side, there is a IT band is there, which attaches over the Gudis tubercle, then the fibular collateral ligament, then the popliteus and the popliteofibular ligament. And this is the posterior part of this posterolateral corner. So about the type of dislocation of the knee joint, the tibial displacement decide the type of dislocation in relation to the femur. It's usually 5 types. Anterior dislocation is the dislocation of the tibia anteriorly, and the posterior dislocation of the tibia, then it is called as posterior dislocation. When the medial displacement, then the medial dislocation. Similarly, on the lateral side, tibia, then lateral dislocation. And when dislocation is having rotatory component, then it is called as rotatory dislocation. In all these, the posterior dislocation of the knee joint having very devastating outcome, because as the tibia move posteriorly, there is chances of injury to the popliteal artery because of the posterior placement of this structure. Like this case, the 19-year male boy having knee injury, and following which he has absent distal pulse, which was diagnosed immediately after injury, and patient was sent to us. Was because of long distance traveling, patient reaches us after 8 hours. And on CT, we can see there is posterior dislocation component of the tibia in this, and there also. And in CT angio, there is complete cutoff of the popliteal artery. So there was absent distal pulse was there. And literature says there is a spontaneous on-field reduction in almost 50% of the cases in such type of injury. So be aware of all these posterior dislocation of the knee. At the same time, don't miss additional injury along with vascular injury. There is chances of neural injury also, almost 10 to 30% of the cases. Chondral and osteochondral lesion is in 15%. A skin lesion and dimple lesion is 5% of the cases also. And last but not the least, the compartment syndrome, which is also frequently associated with knee dislocation, particularly the posterior knee dislocation. So key point in the management of this knee dislocation with multiligamentous knee injury is initial assessment and the evaluation. What should be the surgical timing? Which ligament should we repair and which one should be reconstructed? And which technique we should use? And also the graft selection is also very important. And the last is rehab protocol, which is very important in multiligament knee injury. So evaluation should be a start with the history. We should know the mechanism of injury, whether it's high energy, low energy, what is the severity of the injury also, and the involvement of other system, particularly with high energy injury. And the physical examination should not be restricted to the knee joint only. The knee should be evaluated very carefully, but at the same time, in physical examination, we should also focus on the distal pulse and the skin color of the leg. And also the ankle brachial index, in which the brachial BP at the same time BP of the calf should be measured. Because vascular assessment, if you see the literature wise, only distal pulse is not very sensitive or not very specific. But the ankle brachial index is having sensitivity and specificity almost 100%, both at the same time positive predictive value and the negative predictive value also. So any ankle brachial index of less than 0.9 should need urgent angiography. Like this case, again, young male boy having posterior dislocation of the knee joint. It was reduced immediately, but the ankle brachial index was not done. And after 3-4 days, patient start discoloring of the limb, for which the release of the compartment was done. But in the CT angio, we can see there is complete cutoff of the popliteal vessels. So ankle brachial index would have been diagnosed this condition immediately after reduction of the knee joint. That was missed initially. So ankle brachial index is very important whenever there is a case of knee dislocation or subluxation. The next investigation should they start with the imaging, X-ray of both the sides. At the same time, if any doubt, go for the Doppler ultrasound. MRI add to the data, but it's not the only factor. And MRI in acute setting is not always real. Like in this case, it was diagnosed as a case of PCL, ACL, and the lateral collateral injury. But the clinically and radiologically, it was only ACL tear. So reconstruction of ACL was done. So still debate on when we should get MRI in acute setting. But the common consensus is around 1 week we should wait to get immediate for MRI in acute setting. The 1 week is the ideal time for this MRI. So next is the examination. We should do in OPD also. At the same time, it should be done under anesthesia to confirm its diagnosis. And in under anesthesia in OT, we should also take the help of the stress view, like valgus stress. This should be done at the 0 degree, at the same time at 30 degree. 30 degree for the superficial and the deep MCL, and the 0 degree for the posterior oblique ligament. And it should be done by the normal, it should be done and compare with the normal side of the knee also, and look for any abnormal opening of the knee joint in comparison to the normal side. So this was the grading given for the MCL injury, and examination done at the 30 degree and 0 degree both. At the same time, rotational instability nowadays has been in focus, also has been checked. Grade 1, only microscopic tear, and the opening is hardly 5 millimeter. Grade 2 is the superficial MCL is torn and opening is only on the 30 degree, not at the 0 degree, and there is no rotational instability. And in grade 3, opening is more than 10 millimeter with complete tear of superficial, deep, and the posterior oblique ligament. And usually it is 15 degree joint opening, that is more than 10 millimeter. And opening also at the 0 degree it is present, 0 degree of the extension. And also there is rotational instability also present. The next is the varus stress test. Again, with the stress X-ray also, it should be evaluated and compare with the normal side also. And this stress X-ray is very important when there is a problem with the MRI. We cannot get MRI if there is hardware inside the knee or there is artifact with the MRI. In this case, the stress X-ray is helpful in getting diagnosis. So next is the dial test. Dial test can be done in supine position and look for the external rotation of the foot at 30 degree as well as at 90 degree, and also in the prone position. In 30 degree of knee flexion, if external rotation is more than 10 degree, then is the posterolateral component involvement. And this is excess even at 90 degree, it means there is involvement of the PCL is also there. So this is dial test, also very important test for diagnosing the posterolateral corner. Again, classification of this posterolateral instability also given there, like grade 1. Grade 1, there is no varus laxity, but external rotation is usually less than 10. Grade 2, the varus laxity is 1 to 2 grade, like 5 to 10 millimeter, and the external rotation is 10 to 20 degree. Similarly, grade 3, posterolateral instability means the opening on varus stress test is more than 10 millimeter, and the external rotation is more than 20 degree. So it's very significant rotation as well as opening on the lateral side. So after all these clinical examination, radiology and the MRI, diagnosis made, and classification given by Chenek, classification is there, which is 1, 2, 3, 4, 5, in which one is one of the central ligament plus one collateral ligament. Type 2 is both the central ligament ACL and PCL. Type 3 M is for the medial side, both the central plus MCL. Type 3L is both the central and the lateral collateral. Type 4, all the 4 ligament, ACL, PCL, MCL and LCL is involved. Type 5, when the dislocation is associated with a fracture. Whenever there is arterial injury, V should be added, and nerve injury, N should be added. Though there is other classification also, but the most commonly followed classification is this classification. So after making the diagnosis, the surgical timing, that is also very important, which should be treated urgently, which should be acute, and which should be need the delayed treatment. Like in urgent treatment, those who are having irreducible dislocation, the dislocation which is not getting reduced in emergency, that is called an irreducible dislocation. The mostly posterolateral dislocation is irreducible type of dislocation, and such type of dislocation should be taken to the OT and should be reduced and stabilized with the external fixation. At the same time, the knee aspiration should be done so that all the torn structures should fall into its natural anatomy, will help in their healing also. Next is the vascular injury. Again, it should be treated urgently. It should be taken to the OT immediately. And if there is embolus is there, that should be removed. Or if there is complete cutoff, then the saphenous vein should be, with the help of saphenous vein, repair of the vascular injury should be done and should be stabilized with the external fixator. Any open dislocation should be treated urgently. And about the acute timing for the surgery, that is in between 1 to 3 weeks. Any bony avulsion, displaced or flipped meniscal tear, or extensive either medial side injury or the lateral side injury should be treated acutely. Like this patient, young male boy again, having injury of the fibular head is there. There is fracture in the proximal part of the tibia, and this much of the virus stress. It means there is collateral injuries or central ligament injury is also there. So MRI was done. You can see there is fracture of the anterolateral part. At the same time, the fibular head avulsion and the ACL tear is there. So what is the structure which is attached there? That is the gaudy tubercle part. This is the gaudy tubercle part, anterolateral part of the tibia, where IT band get attached. Over the fibular head, the biceps tendon and the lateral collateral ligament get attached. So this is the complete diagnosis: ACL tear with fibular head avulsion with anterolateral proximal tibial fracture. And the such type of injury should be treated acutely within 1 to 3 weeks. So this is the fibular head fixation with the 2 KY for the tension band wiring. At the same time, pull through technique was also done. And this is the Gudis tubercle, which was avulsed. And at the same time, reconstruction of ACL was also done along with these two component fixation, fibular head fixation and this fixation. So this is also reconstruction of single, if there is one collateral ligament along with the peripheral avulsion, all the thing can be reconstructed or repaired in the same time, which is well supported by literature also. This is after the almost 6 weeks, and this is after the coming following. And you can see with this much he can do. And also, so in such type of injury, the rehab, aggressive rehab is very important. You can see patient is landed on the affected limb also. So with when there is acute repair and at the same time reconstruction of the central ligament, the rehab part is very important because chances of stiffness in such type of injury is very high. Another patient, 35-year male, this is a injury of the tibia and the fibular head, and this much is on the stress X-ray. You can see how massive injury it is. And such type of massive injury on the other, on the medial side, on the lateral side, should be treated acutely. You can see there is nerve is also involved, the common peroneal nerve, the fibular ligament, avulsion, fracture part, all these. Again, stabilization done in the same way of the Gudis tubercle, then the fibular head and fixation. So avulsion part was fixed in this part, and because both the central ligament was involved, ACL and PCL, so this was kept for the second stage for the reconstruction of ACL and PCL. So about the whether should be treated operative or conservative, that there is a lot of advantage of the operative management, like reduction in the fixed contracture, early mobilization and the wet wearing, early return to the work. And the study says there is high knee score in comparison to the conservative management. At the same time, which ligament should be repaired and which one should be reconstructed. So ideally, principle wise, the mid substance tear should be reconstructed and the peripheral lesion or avulsion lesion should be repaired. Like this patient, again having injury to the ACL, PCL, and the MPFL, and the both the collateral ligament was injured, and he was 58 year male patient. In this, the two-stage treatment was opted. First, all the collateral ligament was reconstructed, and this is the medial collateral MPFL and the posterolateral corner part. And when there is 90 degree of movement was achieved, then the ACL reconstruction and the PCL reconstruction was done in the second stage. And this was, he is a teacher, riding cycle almost 8 kilometers every day. And this is after 5 years of follow-up. It was done quite early in my career. So about the graft part is also very important. Which graft should be taken for reconstruct when there is need for the reconstruction of many ligament. So we have option of the bilateral hamstring from the both the limb. Then there is peroneus longus nowadays getting popularity, though still a lot of research has to be done. Bone patellar tendon bone graft, काफी old graft, still in its use nowadays. Quadriceps tendon again coming back for the reconstruction, and the IT band is also available. So every graft is having its advantage and disadvantage. So next, about the technique. In technique, we should focus on the two things in multi-ligaments knee ligament reconstruction. First is tunnel convergence should be avoided, because lot of tunnel both on the medial side, lateral side, on the femur as well as on the tibia, and the proper tensioning sequence should be done in achieving the normal anatomy around the knee joint. So this anatomy has to be remembered about the the medial epicondyle position and the lateral epicondyle position, and then the popliteus insertion. Like similarly in the tibia, while making tunnel for the ACL and PCL, this is the tunnel for the popliteus, and this is for the MCL is on the tibial side. So all these has to be kept in mind. And whenever there is any confusion, always take the use of C-arm for making the tunnel. First pass the guide wire and check with the help of C-arm in multi-ligament knee injury. So with the technique, first the PCL tibial tunnel should be created. Usually it is 10 to 15 millimeter below the articular surface, and there is there is medial meniscus posterior horn, there is Sarpe fiber that should be identified, and below that there is the root of the PCL over the tibia around 10 to 15 millimeter down. So that guide wire right should be there. And on the femur, it can be done from the outside in or inside out, and we can check with the help of C-arm also. Similarly, and after completion of the PCL, the ACL femoral tunnel and the ACL tibial tunnel should be created, and then grafts should be passed both for the ACL and the PCL on the femur, and it should be fixed there. Then come to the lateral side, where the posterolateral corner should be reconstructed, and it should be tension and fixed in 30 of valgus and the internal rotation. And these are the method for the reconstruction of the posterolateral corner. This is the fibular base sealing, that is called as Larson, and the most previously most commonly used technique it is. It is the single tunnel at the femur at the level of the lateral epicondyle. Then technique come with the two femoral tunnel technique with the fibular sealing, because the popliteus insertion is almost around 15 millimeter from the lateral epicondyle. So this is for the popliteus, and this was for the lateral collateral ligament. Then the more anatomical reconstruction technique comes, described by the Laprade method, in which there is two tunnel on the femur, one for the lateral collateral ligament, another for the popliteus. Then the tunnel in the fibula also, and then this is the popliteofibular ligament. This is the popliteus, which goes from the femur to the tibia independently. So this is more anatomical techniques. And after this reconstruction on the posterolateral corner, come again to the tibia part and fix the PCL at 90 and ACL as 30. Nowadays, there is concept again given by the Laprade that first the PCL should be fixed because it's a central ligament. Then go to the posterolateral corner and then come back again, then ACL fixation should be done. So this is still debatable. I am following what I am doing for last 10 years. And then after in the last come on the medial side, where you can do the single bundle MCL reconstruction, or you can do the posterior oblique ligament separately. I do mostly by just the superficial MCL reconstruction with a single with the double sartorius with the sealing over the screw on the femoral side. So this is another patient, which is 50-year male, having dislocation of the knee joint, which was treated with the cast. You can see it is a posterolateral type of dislocation. So it was not reduced with the slab, and patient continued with that. And after removal of the slab, this was the condition. He was the 50-year male, though cartilage was fine, that was identified on the MRI, and there was injury to both the central ACL and PCL ligament, and both the collateral ligament. So all the 4 ligament was torn. So it was more than 6 weeks. So it was a case of chronic cases. At this point, it can be treated by 2-stage or single stage with reconstruction of all the ligament, or in 2 stage by first reconstruction of the collateral, then followed by the central ligament. So it was planned for reconstruction of all the ligament in single stage, and diagnosis was also confirmed under anesthesia by doing clinical examination and with a stress X-ray also. So reconstruction of all the 4 ligament was done. And here I do a little bit of modification of the Laprade to prevent the convergence of the tunnels, because in Laprade technique, there is 2 tunnel on the femur, I use single screw there, over which I do the sealing part, and the rest of the part on the tibia is same as lap rod. So in this way, I escape one tunnel over the femur, and this screw usually I place in between there and there in center part of this. And since it was almost two months was there, and there was little bit of contracture in the soft tissue. So after reconstruction, stabilization with the external fixator was done. This will protect the graft which was reconstructed. So knee will remain in place. There will be very less stress on the reconstructed ligament. So this was removed after a couple of weeks, and the range of motion exercises was started. This was after 2.5 months, 5 degree of extension lag and this much of flexion. So this is the most common complication associated with the multiligamentous knee injury reconstruction, particularly if all the reconstruction done in single stage. So whenever there is a stiffness is there, this can be treated by manipulation under anesthesia or orthoscopic ortholysis. In this case, orthoscopic ortholysis was done at 10 weeks, and this was the movement achieved on the table. And this was the movement after couple of months is there. So you can see there is full flexion and the full extension is there. At the same time, and this is the movement of the patient after 5 months. So it was 50-year made, and you can see reconstruction of all the. So rehabilitation is very important. Patient has gained almost full movement and climbing a stair very comfortably without any limp. So last part is the post of rehab. That is very important. Rehab part vary from the literature to literature. Initially, it was said that the range of motion should be started after 6 weeks, and the knee should be kept in full extension. And recent literature by the Labrard said it should be started immediately. What I followed, that it should be started after 2 weeks when all the suture has been removed, and the range of motion should be started. That is the passive one, and the full movement should be achieved within 6 weeks, and the partial weight bearing should be started after 6 weeks, and it should be varied from patient to patient according to the clinical examination of the knee joint. And full range of motion try to achieve in 10 week to 12 week, and full weight bearing in between 2 to 3 months also. But full-fledged return to the sports and the activity or manual worker or physical worker, that should be allowed only after 9 to 12 months. So recently effort given there a review that is published in 2020, it says almost 18% of the multiligament has associated vascular injury, and the ankle brachial index should be assessed in all the cases, and the angiography should be done if it is less than 0.9, and ischemic limb should be transferred immediately to the OT for repair of the vascular thing and the stabilization. Partial common peroneal nerve having better chances of recovery, and those who having complete recovery, and if not recover within 6 months, posterior tibial tendon transfer should be done. Operative treatment should be done either with the acute or a staged reconstruction. This will provide the best outcome. And the effective repair can only be performed within 3 weeks of injury. After 3 weeks, always reconstruction should be done. On the medial side, they said whether it should be repair or reconstruction, having equal result. But on the posterolateral side, reconstruction has been better result in comparison to the repair. And at the same time, early mobilization following multiligament knee injury will prevent the stiffness of the knee joint. So take-home message is knee dislocation with multiligament knee injury are the complex injury and should require systemic approach to evaluate and treatment, and the good clinical and the radiological examination help in making appropriate diagnosis. And orthoscopically combined ACL and PCL reconstruction with appropriate collateral ligament surgery is a reproducible procedure. Thank you.
Thanks, Arvind. I think we're ready to take any questions from especially the MBA and postgraduate students. Janki, any questions?
Hello, sir. Good evening.
Yeah, Gautam.
Sir, I have a question. If both cruciate and collaterals are involved, and one is planning to do one-stage surgery, what is the sequence of reconstruction?
Reconstruction of all the 4 ligament, as I have said, the PCL part should be done, PCL and ACL part, fixation on the femur.
Okay, sir.
This is what I do, I am telling you. The fixation of the graft on the femur for the both PCL and ACL should be done. Then the tibial part should be left. And then come to the posterolateral side and do the reconstruction of posterolateral, both on the femur side fixation and the tibial side.
Yes, sir.
He said the posterolateral part is the most important part that help in keeping the knee joint into reduced part. Because if you see those who are in posterolateral dislocation of the knee joint, because almost in that cases the posterolateral corner was ruptured, the keeping them in reduced position was very difficult. So the posterolateral reconstructions and fixation should be done first before fixation of the PCL and ACL on the tibia. But recently there is a paper by the Laprade. He says the PCL is the central structure. So it should be fixed both tibia and the femur first before fixing of the another ligament. Because with the posterolateral corner, there is chances of rotational malalignment of the tibia in comparison to femur. But I am doing first posterolateral corner because mostly people does the same, and then the fixation of the PCL in 90-degree knee flexion at tibia, then the ACL at 30-degree knee flexion, then everything finished there, then comes on the medial side. That should be done in the last.
Oh, collateral is the last.
Medial collateral is the last.
Collateral is the last.
Yeah,
okay,
posterolateral corner should be the first.
Okay, sir. And collaterals only grade 3 are repaired. Grade 1 or 2 need not be repaired.
On the medial side, mostly grade 1, grade 2, even grade 3, almost more than 50% cases heal. You have to check after your reconstruct. Suppose patient is having KD type 3M, like injury is ACL, PCL and the medial collateral. So after reconstruction of your ACL and PCL and check for the medial side opening. Many cases in many times after reconstruction of the ACL and PCL, this opening get reduced. If it is less than 10 millimeter, then you can do conservative treatment. If it is more than 10 millimeter, even after fixation of ACL and PCL, then it should be reconstructed. Many a time, this is for the acute setting.
Yes, sir.
Those who are having chronic setting, if you want to do after 2 months or 3 months, so trial can be given for the healing of MCL. Many a time, more than 60-65% of the cases, this MCL get heals by its own.
Okay,
so in that case, you have to do only ACL and PCL reconstruction.
Okay, sir. Suppose after surgery, for stability, we are putting external fixator. Then what is the position of knee flexion?
Yeah, so that was the very rare condition. Till now, I have done in only one cases because this was the posterolateral dislocation, which was kept almost there for 2 months. Even in the cast, it was remain dislocation. So in such type of cases, the contracture of the surrounding capsule and other structure develop. So in that case, if you do reconstruction, knee get reduced, but there is chances of a stress on the reconstructed ligament is very high. So in that case, I apply external fixator, and this should be knee should be kept in neutral position. There should be no any flexion in that case.
Okay, sir.
Sir, one question related to the last one, sir. When you are doing surgery for some athlete person or a sports person, as I have seen you, for grade 2 injury of MCL. In that case also, that is conservative, sir, or you are doing some operative procedure for that?
Grade 2, almost every cases is conservative treatment. Grade 2 don't require treatment at all.
Sir, good evening, sir. Sir, Avinash here. Sir,
हाँ, बोलो.
sir, in case of acute knee dislocation, should we go for close reduction first or should we go for X-ray first?
So reduction is almost should be done in each and every cases immediately. Whenever there is dislocation of the knee joint, it should be reduced immediately. This should be the first step with the patient. And after that, you can go for the X-ray.
Yes, sir. And sir, one more thing, sir. Sir, is there any future of artificial ligament material? And can it be a potential question in DNV, sir?
Yeah, this can be a potential question like what is the recent advances in sports injury. So nowadays for the collateral ligaments like the MCL or LCL, as Janki has asked one question that grade 2 tear for the athlete, those who are having very short duration of time to rest, they have season very frequently. In West, such type of patient get treated with this suture tape augmentation. That is done for the MCL also, for the LCL also, and those who are very athlete, very high demand patient. Nowadays, the central ligament ACL and PCL also get augmented. So this is called as augmentation procedure with the suture tape for all these ligaments. And for artificial ligament independently isolated reconstructed, it has been done previously also, but not very high success rate. And lot of this reaction to all these ligament is there.
Even for the ACL, there's this ligament. There's one is of repair, the concept of ligament repair and reinforcement. So what is the present this thing on that?
Yeah. Sir, I have read about ligament advanced reinforcement system.
Exactly, that's what we are asking about.
Yeah. So nowadays there is lot of paper over this ACL repair, and paper is having more than 2 years of follow-up with almost 87% of the satisfaction rate. So grading has been given for the ACL tear nowadays, 1, 2, 3, 4. So type 1, those who are having periosteal sleeve avulsion from the femoral side with a very short time of injury within 3 weeks, 4 weeks. Such type of patient get treated with ACL repair. They take bite in the femoral end and they get fixed in the femoral tunnel by the swivel lock type of technique, or they take through the drill in the femoral socket and then they get tied over the suture disc over the femoral side. We have done at our hospital 4 cases here also with at 6 months, almost more than 6 months of follow-up with good success rate. IKDC and this lysome score is almost equal to the reconstructed part. In each 2 cases, we have augmented with suture tape, and rest 2 was without any augmentation. And both the cases was having, all the 4 cases is having same IKDC and lysome.
So what about, so ligamentous tears with bony avulsions? Is your approach to that the same, or would you fix all of those?
So if there is avulsion is there and time duration is within 3 to 4 weeks, I take up to 4 weeks. So repair, I try for repair of the most of the cases for this avulsion part of thing. If it is
when you say repair, you mean fixation or repair?
Fixation at the same time. A couple of times we have done
some kind of reinforcement along with it.
Yes, sir. Pull through technique and reinforcement.
Amit has some questions, sir. Amit?
Sir, is there any indication for release of compartment in acute injury settings with knee dislocation?
Yeah, whenever there is pressure is very high than the normal, and if you suspect that because of thrombus is going on, so there is a very good protocol for this knee dislocation or subluxation. After knee dislocation, subluxation, go for ankle brachial index And if it is 0.9, go for angiography. And if it is, there is complete cutoff, then repair immediate. But many a time there is thrombus type of thing and the blood flow is still continuing. We have 2 cases at our hospital also. In such type of cases, monitoring should be done. That is very important for this type of patient. So do the monitoring, start the thrombolytic agent. Again, in every 24 hours, check for the monitoring.
So ankle brachial index, etc., is for vascular injury. Compartment syndrome is different. So I think compartment syndrome would depend on the findings. And if you have a clinical suspicion of compartment syndrome, then obviously you need to watch it and decompress if there's any doubt. If you have the ability to monitor the pressure, that's a good thing to do. But it's really the clinical decision that is more important, okay? So vascular injury and compartment are different because in compartment syndrome, your pulses, etc., will be normal. Your ankle brachial index may remain normal. Your angio will be normal, but clinically the muscle is not getting enough oxygen or the tissues are not getting oxygenated enough, the muscles and the nerves. So that is because of the compartment pressure. And if there's any doubt clinically, monitor and decompress at the earliest possible, okay?
Sir, so fasciotomy is done for all vascular injuries, sir?
Vascular injury is where you repair, okay? So suppose you're doing a repair and especially if there's been any delay, then I think it's almost always good to do a fasciotomy, a prophylactic fasciotomy. Where it is done within 2-3 hours, but that rarely happens in our setup, then you may not need it. But even if there's 3 or 4 hours of delay, I think it's safer to do a fasciotomy because you'll get a rebound effect once the vascularity is restored in the limb.
Sir, if there is meniscus injury, when should it be treated or repaired? Or
So root tear is very common with multiligament knee injury. Many a time complete meniscus get displaced from the joint and come on the medial compartment of the knee. So in such type of cases, try to do repair of the meniscus at the same time. Like as I said, the displaced, flipped meniscus, all these are the indication for the acute surgery in such type of cases. Because reduction of the knee joint become very difficult once it is get trapped in between the femur and the tibia.
And if you have isolated meniscal injury, that's a different situation. I think once you diagnose it, you need to do something. Yeah, that's because that's the different situation. A meniscus today with the peripheral tears, you can repair them. Some of the in between tears as well you can do. But if it's a white zone tear, then repairing it doesn't work. Huh?
sir, there was one question. Management of intraoperative MCL injury while doing TKR.
So the answer is first is to try and avoid doing it. Okay, talk about how you avoid doing it. Okay, and then talk about what you do when it happens. Huh?
So when it's happened, we can do the repair of the same thing and with augmentation of the fiber tape, or you can do reconstruction with the semi-T. You can take the semi-T from the same side, same operative side, and do the reconstruction with that. But the best thing is to avoid the injury to the MC.
Okay.
Because if you're careful, it should not happen in.
So you have shown the Larsen technique, one photograph. Next to that, you have shown there are 2 fixation points in the femur. That is modified Larsen, sir?
It was again given by the Laprade and Gillespie. First was the Larsen technique, which was used for many years. And the recent, that was the single tunnel over the femur, but it is called as non-anatomical technique because the popliteus is having insertion almost 15 millimeter far from this lateral collateral ligament. So the 2 technique was given for the anatomic footprint at the level of femur. But again, on the tibial and fibular side, it was non-anatomic because the popliteus was going in the fibula. It was not going in the tibia. So finally, the final Laprade technique comes for this complete anatomical reconstruction of the posterolateral corner. The advantage of Larsen technique is that is having less morbidity, less chances of injury to the common peroneal nerve and other structure around the posterolateral side of the knee. And at the same time, the less tunnel over the tibia, particularly with the multiligament knee injury. And but it's non-anatomical, and the result of this Larsen in comparison to Laprade technique is less.
What you prefer, sir, that staged procedure or everything in one go for multiligamentous injury? Because the duration and the tourniquet time is also more in that.
Because we have team of our consultant here, almost one consultant is fully trained in orthoscopy, and at the same time the working circulating staff, that is the scrub nurse, is also very trained. They made graft for me. Meanwhile, I do all the tunneling part, so that that time gets saved for me. So mostly cases I do in single stage. Only one cases till now, as shown in this presentation also, that I did in 2 stage. Otherwise, all the cases in single stage. And usually we complete within 1.5 to 2 hours with all the 4 ligament. 3 ligament usually within 1.5 hours.
Yeah, I think if you can do all of them, if they all needed, then if you are operating on them, you may as well do all of them. But it should not become an issue that I have to do all 4 together, because if for some reason there's delay or the tourniquet time exceeds a certain amount, it may be safer not to try and do everything together. Okay. But if you can do it within the time, then the best thing is, because it's like, you don't want to take the patient to OT twice unless it's necessary.
Only one disadvantage of this single stage reconstruction of all the 4 ligament is having little bit higher incidence of stiffness.
Stiffness, yeah.
Than of stage surgery.
So I think you need to look at all that and discuss it. Again, you may think a little different for a sports athlete and a kind of sedentary occupation person. So you need to discuss all those things before you make a decision.
And sir, for these things like multiligamentous injury, they have written into things that allow early protected movement. So protected means you are using some dynamic brace like Sarmiento and all.
No Sarmiento.
It's the braces which will give you a restricted range of motion, allow you to move within a certain range, okay?
And in initial time, it should be passive one. For 6 weeks to 2 months, you should gain full range of motion with the passive movement, and then you start active movement of the knee joint. And the partial weight bearing should be started usually after 6 weeks to 2 months only. Weight bearing should be restricted completely in this multiligament knee injury. Because
so what is protected in protected movement? Means it is only flexion extension?
Yeah, it's the passive range of motion till 6 weeks. And non-weight bearing patient can walk. He should not put weight on the operated knee. Because in all the multiligament knee injury, in our series also, there is grade 1 laxity of the PCL. At the same time, the posterolateral corner is almost in 20% of the cases. Every 4th patient is having grade 1 laxity of these, either of these 2 ligaments.
One more term is given like internal brace for probably MCL. So what is that one? Internal brace. That.
Yeah, what I said, augmentation. Now I am doing in majority of this multiligament knee injury. This as you reconstruct or repair your MCL, at the same time you put this fiber tape in the same tunnel what you have used for your MCL or LCL. And sometime I use for the central ligament ACL and PCL also, if patient is very bulky, very heavy patient, or very high demand, or very laborer patient type of thing, in which I uses this the internal brace also. This prevent laxity of my graft also.
Okay, I think that's great. If the DNB students have any more questions, otherwise I think we should
Sumit,
call it.
everyone has asked, I think. If you have any doubt, you can ask.
No, sir. Gautam has already asked all the questions.
Okay, great. So I think in that case, we will call it a day. Thanks, Arvind, and we should close the meeting now.
Thank you.
Any other questions? I'm sure you can ask directly to Arvind, and he'll be happy to answer them. Okay, great. Thanks.
Yes, sir.
Thank you, sir.
So nice.
Sure, bye. Good.